You all are here to learn, and I'm thrilled about that because what you're here to do is learn how to take better care of these patients that have this horrible, devastating disease. They are in need of every one of you. It doesn't matter if you're a nurse practitioner or if you're a registered respiratory therapist or whatever you do and however you touch these patients, you can learn from all these speakers up here today. So I thank you for being here. So today, I get to talk about how we go about figuring out the puzzle. You know, patients present to us with a complicated puzzle, and it's our job in pulmonary to put these pieces together. So I just want to kind of give you kind of points of things to think about, just like in the previous lecture you saw that in the history the patient had pigeons. Oh, that's a clue in, you know, so my presentation is kind of full of little clue-ins for you to figure out, could this be one of 200 different interstitial lung diseases, all right? So despite the cascading, you know, you see this long boxy list of things. If it's this way, there's like 7 different areas of disease. I think there's 2. There's known causes and there's unknown causes, right? So the known causes are a little easier to figure out. It's figuring out what's going on in the patient's past, figuring out what's in their medical history, figuring out what kind of drugs they've taken in the past, and putting those things together. The unknown ones are a little harder to figure out. So we have occupational and environmental exposures. We have drug-induced pulmonary toxicities. We have radiation-induced. So if somebody comes in and says, I had breast cancer 5 years ago and I took radiation and now they've got fibrotic lung disease, there's clue-ins there. Fungal, bacterial, and virus-related problems. You see these in your immunocompromised patients. So an HIV patient that presents who's got fibrotic lung disease may have had a bacterial problem, and this is what the result is. As you all know, especially with the scleroderma new publication that's come out with OFEV, connective tissue disorders can account for interstitial lung disease. So we have a variety of connective tissue disorders that can be associated with this. And as many of you know, patients can present with the lung disease first and then, be told they have IPF because everything else doesn't sound right, to wake up a year later with swollen and sore knuckles and their rheumatoid factors off the top of the chart. So always keep these things in mind. And then, of course, your idiopathic causes of interstitial lung disease include this variety of alphabet soup, as we've already been through today. So in the idiopathic interstitial pneumonias, we have quite a variety. All right, so to get down to it, people all seem to present with the same thing. Shortness of breath with exertion initially, and a non-productive cough or a non-productive cough. But you want to dig a little deeper. When you're thinking about symptoms, you want to think a little deeper. Is there any other symptoms associated with any other diseases going on? Is there any history associated with a different type of cause of this lung disease? And don't just automatically label something idiopathic when there could be something else going on. Are there any labs associated with another cause? What does that CT scan look like, and what is that biopsy? So that's all part of putting your puzzle together. All right, so in pointing fingers at things, if I'm looking at a patient, it's a much younger patient, like a 40-year-old female maybe, then these are the diseases I want to look at. If it's an older patient, then I'm really going to start thinking about IPF. So consider the age of your patient, consider the gender of your patient. IPF tends to happen in more men than in women, but in occupational exposures, we're going to see that more commonly in men. Believe it or not, we actually see more men with rheumatoid arthritis than we do women. So think about these things as well, not just the traditional things we think about, but think about the age of your patient, the gender of your patient. How did the symptoms onset? Was it a gradual thing? Indolent is what I've got on the next slide, or did this come on over a couple of months? If it came on rather quickly, these could be your possible candidates that would end up being your diagnosis. And then again, chronic or indolent, onset? Is this a gradual thing that you kind of think of? Last Halloween, I was able to walk my grandchildren around the neighborhood, and this Halloween, I'm not able to do that. So kind of think about those things. Dig into that medical history. What's going on? What are the other diagnoses that this patient has, or maybe diagnoses that haven't been found out yet? One of the things that we always find when we're reviewing new patient results, especially for clinical trials, it kind of crawls all up under my skin, is I want to put this patient in your IPF trial, and the next diagnosis on the list is rheumatoid arthritis. So, that's an education point, but think about all of the different things in medical history. If they've had a malignancy in the past and they had radiation, as I mentioned, like breast cancer and radiation to the chest, maybe the cause is a radiation injury and not IPF. Smoking history plays a difference as well. We all know, and it's kind of nice to say smoking doesn't cause your IPF, but it's a risk. And I've got IPF starred there under both current and former tobacco users and never or remote. It's amazing how that is such a vast difference. You look at one paper and it says 65% of the people used to smoke or are currently smokers. I mean, it seems like in my population, even though I'm from the South, nobody smokes or had never smoked, or I tried cigarettes, a half pack in high school, and that's all I had of it. So it's really kind of very variable. Family history, incredibly important. Sometimes we hear patients say, why is everybody so interested in my hands and my fingernails? My hands look just like my Uncle Jimmy. So paying attention to family history. Is there anybody else in your family that had this disease? Was there anybody in your family that was on oxygen and was a never smoker? So dig down into that family history. We are finding that IPF in about 20% of our population is indeed a genetic thing that's going on as we discover more and more genes that have caused disease in family. There's some studies going on about sarcoidosis also being familial or have a genetic basis, and I think we're going to see more research come out in that soon. Dig in, just like you dig into medical history, dig into what kind of medications patients have taken in the past, and pay close attention to these 6 down here at the bottom. There's a lot of drugs out there that can cause pulmonary toxicities, so if you're ever curious, go to this website and check it out, and it'll tell you to kind of a degree of what what the likelihood is that drug can be causing that lung disease. But amiodarone users, macrodantin users, bleomycin taken for different types of cancer, those are all good indications that you can point this at a drug-related pulmonary toxicity. Again, occupational environmental history. What has that patient done for his life? What has he gotten his elbows in at work and dug around into? What kind of hobbies does he have at home? How many times do you hear patients say, when you ask them, so how is your breathing? They're going to answer that question. Many times they're not going to go into detail, especially the men. They're going to say, so you say, how's your breathing today? And they say, oh, I'm fine. And the wife's sitting over there fuming, That's not right. When you're at home, you can't breathe. Well, I'm breathing fine now. So, you got to get into how is it at work? What is your breathing like at work? Do you cough at work? What are you around at work? What brought you here? So a lot of times those symptoms that you see when people are around the item that's causing the problem, they flare up in those environments. And just like the people that are around their birds, they're worse at home. If their house is moldy, their breathing is worse at home. If they're around a certain chemical at work, their breathing is worse. And they leave that environment and they feel fine, and they tend to say, well, I'm not worried about it anymore. Maybe it's really not bad. Maybe it was all up here. So that medical history purge of data, sometimes on your first visit with your patient, you're going to spend a good hour with them just talking about the past, just getting into their life and really understanding things. And the notes that you write on that first initial visit are very important because you're going to refer back to it. A lot of times it's very important, too, to have your patient complete an exposure history questionnaire. And you might send that to them before their appointment to fill out. There's a lot of different exposure history questionnaires. I personally think that we have the best one. But it's a combination of the one provided by the PFF and the one that's out there on ATS and our own kind of little thing that's going on. So we combine all of those different ones and send it out to our patients and ask that they bring it in on their first appointment. Those questionnaires are full of valuable details. So we slip into our physical examination of our patient. So of course, very benign examination. When I'm listening to the lung sounds, I want to listen and see if I hear crackles or Velcro-like rails in the bases of the lungs. That's very telling, but a lot of these lung diseases are going to have that, all right? If I hear inspiratory squeaks, high-pitched rhonchi, then I might be thinking of bronchiolitis or HP. Sorry. Cardiac exam, benign, very normal. I'm going to listen to heart sounds, and typically it just sounds like a normal heart in most of these patients, not considering people that have, bad CHF or other things, but typically you hear normal S1, S2. In advanced disease, you might hear some sounds that'll lead you to believe that this patient might have some pulmonary hypertension going on, so a loud P2, maybe you'll have a right-sided lift. Clubbing is present on about 50% of our patients, and it's just a finding, right? It's kind of like Raynaud's disease. That's a finding. Clubbing is not necessarily going to say, oh, this is IPF, it's just a finding, so document your findings. And I like to say that, clubbing, when I see it in an IPF patient or in most of our pulmonary fibrosis patients, it's not significant, bulbous, drumstick-looking clubbing. It's very mild in most of our patients, so mild so, like I said, they don't really recognize it. Their hands look normal to them. Their hands might look similar to other members of their family. And then get out of that. Take a step back and get out of the heart and the lungs and the fingertips and pay attention to skin. So this first finding here is mechanic's hands. Does anybody know what that makes you think of? Antisynthetase syndrome. So mechanic's hands runs in my family. So I've always paid attention to what people's fingers look like, and sometimes their fingers are so bad that they bleed. So if you look at your patient and he comes in and he's got blood streaked on his blue jeans, he's probably been doing this all day, okay? So that's kind of one of those clue-ins. If he's got hands that look like that and he doesn't work in the labor field, maybe he's an architect or something, so pay attention to those things and do the appropriate blood tests. That second picture is a picture of cutaneous sarcoidosis. Get your patient out of their clothes. In this role, especially on your first examination of the patient, get their shirt off, put the cloak on or whatever, and take a good look at their skin. Nobody does that anymore. Do that. Patients appreciate the fact that they've come to you. They want a thorough examination. Look at their skin. It's very telling for these types of lung diseases. And then finally, that last picture is sclerodactyly. We're going to see that in some bad scleroderma patients. So pay attention to what their hands look like. Sometimes I've actually even, I could come in and I'll draw blood for research purposes or for whatever for our patients, and I'll be looking at what blood tests are ordered and roll up that sleeve and put something on. I'm feeling that arm and I'm like, wow, this is really thick skin, and double check to make sure we've ordered the appropriate labs. So pay attention to how the patient's skin looks and how it feels. Appropriate laboratory tests first visit. We want to order some regular things, but pay attention to your lab results. If you have elevated liver function, maybe this could be a little bit of fibrosis going on in the liver. Maybe it's just a fatty liver, but maybe this guy has short telomere syndrome. Having short telomeres can cause problems with your liver and kind of be a clue into, could this lung disease be related to short telomeres? Could there be a TERT or a TERT mutation? Blood counts, an elevated white blood count, that could be infection. Does this guy have an unknown history of HIV, or is anything else going on, or HP? And of course a BNP. If it's greatly increased, then we know that there's probably a problem going on with his heart. Then we get down to more specific things, and I love this slide. This is a refer to, go to slide. And one thing I do want to say is whether or not you see these findings on exam, draw these samples. Pick 5 of them that you want to draw on every one of your patients. A lot of people are going to come up positive on an ANA, but it might just be a smudge positive, 1.1 to 320 or something like that. But check out these different things. So there's some symptom findings in the appropriate test you should draw for those things. But typically we do about 5 of these different studies, and if any one of them pop up positive, regardless of the lack of symptoms or findings, we'll send them to rheumatology to get a good, thorough review. Make sure they don't have a rheumatologic disease. And as referred to before, do some antigen testing if you're concerned about HP. This will only lead you down that exposure kind of area and help you understand a little more about what that patient's been exposed to, but it's not really diagnostic in nature. All right, pulmonary function test. We do it on everybody. Is that going to tell you which kind of fibrotic lung disease patients have? Not at all. It's only going to tell you one of 3 things. This is normal spirometry, or this is restrictive spirometry, or this is obstructive spirometry. That's all it's really going to tell you. So in our patients, especially early on in this disease, they're either going to swing to the normal or they're going to be restrictive. I'm not going to get into discussions about people that have combined fibrotic lung disease and emphysema, because that's a little more challenging when you're looking at PFTs. But in our situation, pulmonary function isn't really going to tell us which disease this patient has. So those of you in here that do pulmonary function tests, you're used to seeing this slide deck, but do you all understand how to read a set of pulmonary function tests? So here's this is the down and dirty. So if you only do a spirometry, then you want to look at the FEV1 FVC ratio. All right, so you look there first. The number that you're drawing the line at is 70%. If you're 70 and higher, that's considered to be normal. If you're under 70, you're obstructed. All right, so this is like PFT 101, right? There's a lot more to this, but we're only on the 101. So 70% or higher is normal. So the next thing I want to do is I want to look at their FVC. I'm only doing spirometry, so I've only got FVC to look at. So if I look at my FVC and I'm looking again at this line, this time the line is 80%. If it's under 80%, I'm restricted. If it's over 80%, I'm normal. Does that mean he doesn't have a lung disease? No. It just means our findings haven't affected the function of the lungs to that degree yet. Okay? So you could have somebody that has IPF whose FVC is 85%. They just have normal spirometry. All right? But if you fall down below 70% or below 80%, then you have a restricted spirometry. You want to verify that. So you can send patients for a full study or just capture a diffusing capacity. The total lung capacity is the TLC. That should kind of mimic your FVC. So again, if it's below 80, that's your confirmatory restrictive pulmonary function tests, all right? Diffusing capacity will likely also be lower than normal, all right? You can grade severity, but that doesn't really classify your patient. So I think that was one of the problems we've gotten into the past is that, oh, he's a moderately restricted spirometry. That means he's got he's this far down the road. That's not necessarily true either. You just kind of have to keep in mind that is just defining his pulmonary function. So severity is from 65% to 80% is considered mildly restrictive. 50 to 65% on the FVC is considered moderately restricted, and then below 50% is severely restricted lung disease. All right. A lot of times when we're moving towards transplant, we're down under that 50 percentile. A lot of times in clinical trials, they're kind of avoiding the patients that are under the 50th percent or the 50th percent. They want to have patients that are a little more moderately restricted to see if they can slow those things down. You've likely seen this flow sheet before as well. So this is kind of what we do. You sit and talk with patients, spend a lot of time getting the meat of what's gone on behind the scenes, in the background with the patient. Then you do your pulmonary function tests, you do your labs, and depending on which way you might go down this path, I think, I'm kind of the person that says all paths lead to a CT scan, all right? So regardless of what this flow sheet says, all paths lead to a CT scan, and by guidelines, all paths also will go to a multidisciplinary discussion, if that's available. And we understand that that's not always available, and certainly not always available in a face-to-face format. But what is always something that we need to do is talk to other providers, all right? Especially with these challenging cases that aren't right out of a textbook. Talk to your peers and make sure that you've correctly diagnosed this patient. It makes a difference, of course, with what you're going to treat people with. Do you want to give people prednisone, or do you want to give them one of the two FDA drugs that cost a lot more money? So, I am not a radiologist, so I'm going to step back and say I am not a radiologist, but I'm going to show you a few radiographic slides so you can kind of see what's going on inside these patients' lungs and see what we're looking for. So more alphabet soup. IPF does not always mean they've got, or I should flip that. UIP is what we see in CT scan, but it's really what we see under a microscope. So with all of our years of doing research, we've learned that CT scans are going to look a certain way if we have a biopsy that says they have a UIP pattern, okay? So the whole reason of doing this and seeing if they look a certain way is so that we can avoid doing a biopsy. The last thing I want to see come across my desk is somebody that's got a pattern that is definitive for a UIP pattern on a CT scan, and they got sent to a biopsy, and then they went and had an open lung biopsy or something like that. So if you get this pristine picture of a definitive UIP pattern, you can stop there and you can put your puzzle pieces together, all right? So the things that we want to look at, I don't know if this has a pointer, it doesn't look like a light shine it in my eye. The things we want to make sure we see for a UIP pattern is peripheral predominance, peripheral and even basilar predominance. So that means all the stuff is happening in the periphery of the lung and at the bases of the lungs. That's true for most IPF patients. People that have familial IPF typically have these findings in the top parts of their lungs. We want to see reticulation and we want to see honeycomb. So honeycomb is the key for the CT findings for UIP. You're not going to see that in other findings. So honeycomb pattern is this right here. Cystic areas that kind of stack on top of each other. And depending on the radiologist in his training, he might just call one row of cystic changes honeycomb, and some people are trained, I want to see a stack of them. Maybe I want to see 2 rows at least to call that honeycomb. So here's some more pictures. Maybe not. We're going to come back to that. Maybe. Here's some more pictures. So this is that's NSIP. Hang on, we're still talking about UIP. Did they not get in? Well, all right, so you don't get more pictures. All right, so NSIP, as we've talked about, is in that category of idiopathic pulmonary diseases, but they look a little different. So a lot of times what you're going to see with NSIP, and I got a little note on here, they call it nonspecific because really there's nothing there that points us in any particular direction. On a UIP biopsy, one of the features we're looking for is this thing called a fibroblastic foci. All right, but in NSIP, there's nothing really there that kind of points us in any one particular direction. So a lot of times with NSIP, you're going to see this patchy ground glass, all right? So when you say those words to patient, honeycomb and ground glass, they get to thinking about those things and they're saying, do I really have this stuff going on in my lungs? So it's just a picture, it's just how it looks on CT, all right? And you see that with NSIP, it's going to be more centrally, located, all right? It is more basilar, but you see it more centrally. Look at this. This is nice. This is ground glass, and see how much different that looks than honeycomb? You know, you don't see those cystic changes stacked up on each other at all. Try thinking about breathing with this in your lungs. And this is just one slice. All right, so again, CT patterns can change. It's not just one picture. So sometimes with some diseases, it changes with the course of the disease. Sometimes people say NSIP, these non-specifics, are the prelude to UIP. So while it's important to get CTs to make a diagnosis, and a lot of times we'll say, well, we don't follow CT scans over time. We're not going to do another one in 6 months or in a year just to see what it looks like. I can tell you what it looks like. Sometimes when you're really questioning if you've got your diagnosis right, it's important to get CTs repeated over time to see if you see some changes that'll help you and point that finger a little closer to a more confident diagnosis. So here's another shot of fibrotic HP, and you can see air trapping. So air trapping, if you look into the kind of the meat of the lung, that's that mosaic pattern where you have lighter patches and darker patches. Dark is air. Dark is a good thing, but you can see all these lighter patches and darker patches. That's called air trapping or mosaicism. So those are clue-ins as well to kind of help point you to one direction or the other. So finally, when you get to the point of, well, do I biopsy? All right, do I need to know? Is there a reason to move any further? And to move further, you got to first ask that question, is it safe to do that in this patient? Is it going to change the way I take care of this patient? So is it going to make me choose between high-dose prednisone, or is it going to make me choose between nintedanib or pirfenidone? So you got to have those kind of questions before you put your patient through a biopsy. A biopsy holds a 5% mortality rate. So I've seen people who were completely functional, working as pharmacists 40 hours a week, doing very well, not survive. So you really got to know the answer to the question, all right? In most cases nowadays, you can get those answers with a CT scan and avoid a biopsy. So if you have different things going on, especially if your patient is on high oxygen needs and is older, has a pretty bad, severely restricted lung disease, then maybe this isn't the best choice for you to do. With your biopsy, what are we looking for? We're looking for this UIP pattern. And just like I said, these kind of things, this definitive UIP pattern, you're going to see dense fibrosis, architectural distortion, fibroblastic foci, patchy involvement. Those are the things that we've learned over time look a certain way on CT scan, all right? So these are the 4 characteristics you're going to see with a UIP pattern. Different disease processes will present with different findings. And what you want to do eventually is match those, your biopsy for findings with your CT findings. And I've got that grid up here as well. Here's a nice example of a normal lung, lots of air. That's what that white is, lots of air, single cell alveoli. Compared to a fibrotic lung disease, and this is probably a UIP pattern where you have nice lung tissue right smacked up against a fibrotic tissue. Here's our multidisciplinary team. Look at everybody going at it. And here's that chart I was talking to you about. So while this thing is a nice thing to have, it's not set in stone, certainly, all right? But we're looking across the top. That top section is our pathology findings of UIP, probable, indeterminate, and then we've got our CT patterns of UIP. So if you match these two together, then you get your diagnosis in the middle. A lot of times we don't have to use this anymore because we have our CT scan, and in most cases, CT is your final thing. You don't have to move forward with biopsy, but you do need to talk to other people. And that's the whole purpose of a multidisciplinary discussion. Make sure that you talk to your radiologist, talk to the pulmonologist, I love the fact that they include nurses in many of these multidisciplinary discussions, and they make decisions about management. One quick slide, and I don't know a lot about Vizia Testing, but I think you're going to see more and more about that. That was a recent publication earlier this year. Dr. Ragu was the lead author on it, and it talked about the BRAVE studies out there where we compared surgical lung biopsy to transbronchial biopsy to cryobiopsy, looking for the best way to figure out UIP. They added this special thing in there called machine learning, this Vizia profile, and now we get high specificity, 88%, and sensitivity at 70% for UIP positivity in transbronchial samples. This is something that's newly approved by Medicare. We're starting to use it in our practice. I think one of the previous slides said CT has a specificity for UIP at 43%. So I don't know how often this is used yet. Like I said, it's pretty brand new, but it's worth reading about and looking into to get a better or a more confident diagnosis for your UIP patients. We measure telomere length on our patients as well, just to get more data. People that have a telomere length that's less than 10% or less than the 10th percentile are more likely to have a TERT or a TERT mutation. Very informative to us, and can help us understand other things like liver problems and skin problems and different anemias. Genetics, there's a lot of genes out there that are pointing the fingers at certain family members. So at our center, if I have 100 IPF patients, 20 of them are going to be from families, and of those 20, I'm going to know the gene responsible for 4 or 5 of those families. So we're coming a long way with genetic research as well. Thank you so much for your time. And I am going to maybe introduce the next speaker. Okay, so, yes, ma'am.
You said you guys check telomere length on all of your patients.
Mm-hmm.
Is that covered by insurance, or do you guys do that through your research study?
We don't do it through research study. I would love to be able to do it through research study. It's not as expensive as it once was, and when we do it through Vanderbilt, like I send the lab up to the Vanderbilt lab and then it shoots out, I think it costs about $350, and most of the time insurance will pick that up. Don't sign my name to that. But we always use a company called Repeat DX. I believe they're based in Canada, Vancouver-ish area maybe. But you get results back in about 3 weeks. And they don't want NPs signing the stinking prescription. That's my complaint. Anybody else? Did I see another hand? That's just telomeres. So for the whole genetic panel, there's plenty of different companies that do different things. Right now, I can't remember. Dr. Lloyd just switched us up. Sometimes he'll switch us up. Start sending everybody over here. But we've used Greenwood Genetics. We've used Cincinnati Children's Hospital. We've used, I think initially we used one place in Chicago, but I can't quite remember of where we go now. But you can get, one of the nice things about genetics is you can have the patient get their whole genome sequenced now, okay? So when they sequence, so when you send a blood sample in, they're going to sequence the whole genome, but they're going to report on these few little genes we know about. But if the patient signs the consent, they can send you the whole genome, all right? Now, if you're not researching genetics, that's of no use, because it's a stack of information. But get them signed up with the center. So Denver and Vanderbilt do genetic research on sporadic and familial IPF. Get them signed up with our programs, and we can use that data.
One more question. You said you don't routinely follow CT scans on stable patients, and we don't either. But I've had a couple of patients recently that hadn't had a CT scan in a couple of years and just started feeling bad. They had stable PFTs, so we repeated and found some big lung masses.
Right.
So I'm just curious.
Incredibly important. So what I'll tell patients is I'm not necessarily going to follow this because we know your diagnosis. We're using the CT to diagnose the disease. But if you have changes, I'm coughing up blood, I've got a new problem going on, absolutely we're going to take another look in those lungs and see if we find a mass. Our patients are more prone to develop lung cancers.
So you don't have any set frequency that you guys use either?
Mm-hmm.
Okay.